Yeah, madam, we are on live. Please start.
Good evening, everyone, and welcome to today's webinar on antivirals in COVID-19, which is hit hard and hit early. We have with us our eminent guest speakers, and I would like to take a moment to introduce them. We have Dr. Chetan Kumar. Dr. Chetan Kumar is the consultant pulmonologist at Sparsh Hospital and Vegas Hospital in Bangalore, and also is associated with Sharda Asthma Allergy and Chest Clinic Bangalore. He also has a wide experience with COVID-19 management. We also have Dr. Sandeepa, who is the consultant interventional pulmonologist with us. He's associated with BGS Glenius Global Hospital Bangalore. Dr. Sandeep is also the board member of Institute of Pulmonary Medicine Research and Development and holds many publications to his credits in various national as well as international medical journals. He also is associated with the COVID-19 management and has a wide experience managing lots of patients of COVID-19. With this short introduction, we'll begin the webinar, and I'll hand over the session to Dr. Chetan, who will take us through the insights of the antivirals in COVID-19. Off to you, Dr. Chetan.
Okay. Thank you, Mona.
Yeah.
Good evening, all listeners. So welcome you all for this today's session on antivirals in COVID-19. So definitely it's a ball game of antiviral in COVID. So the main gist of our talk today is hit hard and hit early. So why hit hard, why hit early? So we're going to discuss all these things in the coming 15 to 20 minutes. So the contents, basically COVID-19 current scenario, COVID-19 positive and asymptomatic, benefits of starting early favipiravir, importance of treating family members, post-COVID complications, and home quarantine norms, diagnostic tools, and inflammatory markers. So COVID-19 pandemic in India, present scenario, of course, this updated version would be affecting more than 16 million people and claiming affecting more than 71 million and claiming more than nearly 16 lakh lives all over the world. So it's still updated, the numbers wise. As on 1st December 2020, 94.6 lakhs cases reported in India and 1,37,000 deaths have happened. So the numbers actually, on so many unreported cases to add on, it will nearly become 2 plus to be precise. So Indian Medical Council of Research mentioned that 80% of the cases in India are either asymptomatic or mild, 15% moderate, and 5% critical. The experience is pretty much same with our practice also. Somewhere around 85% mild asymptomatic cases, and the rest 15 who all require the hospitalization. So the challenges is rising number of COVID-19 positive cases, limited healthcare infrastructure. Definitely our country was not ready for this challenge of this number of cases, which posed upon in the month of June, July, August, September, till late October. Still in many metropolitan cities, we have seen the surge of second wave. Of course, Bangalore, there is yet to experience the second wave of COVID. Cost of COVID-19 treatment, increased incidences of post-COVID-19 complications, even in asymptomatic patients. So these are some of the challenges we are facing, including the cost of the treatment. So basically, COVID-19 is a viral disease. So one has to be very precise in history taking. That's where the role of, our whole concept, hit hard, hit early, comes into picture once our history taking is solid. So we need to know how the COVID-19 infection present to us. So basically, it's an acute history with cough, shortness of breath, difficulty in breathing, fever or chills, which is classical for a viral infection, muscle and body aches, vomiting and diarrhea. Of course, COVID is basically a respiratory illness, 85 to 90%. Of course, 10 to 15% of the cases do present with GI symptoms and other symptoms like loss of taste and smell. So this, apart from all the viral illness, to club together the symptoms wise, this new loss of taste and smell is one significant symptom to bring a part of the COVID. So that is one of the clinching symptom to confidently tell as of now, to be precisely tell it as a COVID-19 infection. So I'll come into details of that also. So classifying of COVID-19 patients. So how do we classify? The basic parameters to classify is basically whether they have a symptom, whether they don't have a symptom. So asymptomatic and symptomatic. In symptomatic, whether they're in mild symptoms, moderate or severe. So to go with the symptoms, the main differentiating parameter would be the pulse oximetry. So if the pulse oximetry is more than 95% after brisk walking for 5 to 6 minutes, they are still categorized as mild. So the amount of fever, the difficulty of breathing can be there, but if the pulse oximetry is 95% above, in spite of brisk walking or small exercises, if it is above 95%, we categorize them as mild. Moderate is where once the saturation starts dipping below 94%, and severe it's once they start dipping below 90%. So the hypoxemia based on pulse oximetry is the main clinical parameter which we take into account for categorizing mild, moderate, severe in an OPD basis. Of course, we need to look into the respiratory rate, the pneumonia, and if they have an X-ray already, we need to see all those into consideration apart from the respiratory rate also. So symptomatic differentiation of influenza-like illness, H1N1, SARI, and COVID-19. So definitely there was a lot of discussion in the initial months of pandemic whether we need to test everyone or whether we need to go with a history, symptomatic approach. Basically, we all know that swab reports were not 100% sensitive. So that's where we found the challenge of waiting for the swab reports and delaying in adding an antiviral or effective treatment to the patient. So basically it all boils down to the history taking, and one should understand in a pandemic, when the pandemic in its peak, most of the acute cases of cough, fever, viral cases will be predominantly of a COVID. So 95 to 90% of the cases will be COVID. So let us not break our head too much and thinking about other kind of viruses or illness presenting it, because it's a pandemic. We know it's in a community spread phase 3. So definitely the majority of the cases will be of COVID itself. So the symptoms includes all the same, which includes for the other viral illness. The only thing differentiating is the anosmia, loss of smell or taste, what you say, is the only thing which we can confidently tell it as a COVID based on history taking. Whether other symptoms do overlap with COVID, with H1N1 earlier, we could see the same kind of fever, myalgia, cough, headache, diarrhea. All these symptoms we did face in the H1N1 era also, when in the 2015 epidemic. So history taking, along with knowing the geographical setting, knowing what's happening around. So what cases are we seeing in and around? So that gives an precise idea of what exactly the case is based on pure history taking. So coming to the swab test, which is being done all around, the RT-PCR test, reverse transcription polymerase chain reaction, is the most sensitive technique compared to PCR. Of course, we don't have any other 100% sensitive test, so it is being used widely. So definitely, I am not depending on the swab report, nor do Dr. Sandeep also. He will explain it later. So because we all know it's only 60% sensitive, so the onus should be given on the kind of presentation and symptomatic approach. So the RT-PCR is commonly used in studying the genomes of viruses whose genomes are composed of RNA, such as influenza, HIV, and SARS-CoV. So definitely you can ask for a test, but we should not delay in starting the treatment, because already the patient presenting to us would have wasted their time at home by doing all home remedies, or wasting their time taking over-the-counter medicine. So we should act fast. That's the whole gist of the talk today. Hit hard, hit fast. And coming to the X-ray, once the patient comes to the OPD, definitely we'll all ask for X-ray in a resource limited center. We can ask it after some days from another center. But of course, now I think all the hospitals and clinics are having an X-ray center attached to it. So one should know what are the signs you expect in an X-ray. the peripheral damage to the lungs, multiple areas of patches seen, especially in the periphery and in the lower lobes predominantly, and it usually is a bilateral picture. So all the kinds of viral LRTI or pneumonia gives a bilateral picture, predominantly in the lower zones. Coming to the CT, of course, we are not using much, only in the for the insurance purpose when the swab reports are negative and we are suspecting COVID. Definitely, we do CT to explain the patients better of the lesions and convey that they're COVID, because it's a stigma for the patients to accept that they're having COVID infection. And it's very tough to convince them once their swab reports are negative and they're having symptoms of COVID. So for insurance purpose and to counsel the relatives better, so we do CT, and most common feature what we see is this ground glassing opacities, which is predominantly seen again in the bilateral lungs, in the predominantly in the lower lobes. So diagnostic tool for differentiating all this, definitely for all viruses, we were using pulse oximetry, and I am using pulse oximetry, and I'm strongly advocating it for all. I do tell all doctors now it's a must to keep a pulse oximetry with them, which we can confidently, categorize all patients into mild, moderate, severe, and bring down lot of anxiety, bring down lot of unwanted tests, bring down unwanted admissions. So simple pulse oximetry can do wonders if used properly with a proper technique and at a proper time. So I request all the general practitioners who are listening to the talk to kindly, if you don't have it, kindly buy it, use it, and advocate to all your patients who are at home quarantine, at least have a pulse oximeter at home and monitor their symptoms effectively. Of course, chest X-ray we discussed, CT scan, PCR test, and complete blood count to see the lymphocytes count, because the lymphopenia is one of the marker for a viral disease. So lymphocytes, we all know the normal values. So the lower the WBC count, there will be a suggestive value for a viral disease. Of course, D-dimer. See, D-dimer has a high negative predictive value. So we can virtually rule out pulmonary embolism if it is less than 0.3. But all these markers, D-dimer, CRP, ferritin, IL-6 are all acute injury markers. Means once the acute phase reactant, once the viral infection is infection happens to us, so these markers are bound to increase, but that need not correlate with the clinical condition. So that must be understood. But widely, what has happened from the Western data experiences, it has been widely done to all patients, irrespective of their symptoms, whether they're asymptomatic, mild or not. And more relevance or more reliance or the more dependability on these markers is causing a harm to the patients actually. So we have seen many patients getting unwanted remdesivir, steroids based on these markers also, or unwanted medicines, anti-IL-6, tocilizumab. When the clinical condition of the patient is very good, when their saturation is good, but somewhere the panic-driven medications have been seen based on this marker. So that has to be avoided. So what all the markers we do or we see in the report, it has to be related clinically. So it has to match the clinical conditions and our markers. Complications of COVID-19, of course, pneumonia is the predominant, complication. ARDS, major, as we discussed, all those severe cases do end up with ARDS, 5 to 6% of the cases. Sepsis, septic shock, cardiac failure also have seen, and renal failure. Renal failure, of course, we have seen acute kidney injury and then recovering once the infection settles down over a period of 2 weeks. So the complications, not all patients face all complications. It depends on the stage which they come and how effective the treatment is and how they behave post 2 weeks. Many do, we have seen what is all those moderate severe cases who have come late to us, who are delayed in taking a steroid or antiviral, have ended up in going for a post lung fibrosis. So that's the role of where today's discussion, role of antiviral and favipiravir. So we all know only two antivirals are there effective for this COVID-19 infection. One is favipiravir and the other is remdesivir. So favipiravir roles comes in the mild to moderate conditions, basically in the OPD kind of setting. So mainly general practitioners, you are the ones who should know about the drug more, be more confident, and use it upfront. And you should not have any hesitancy in starting antiviral, because all our teaching, all our culture, belief, and behavior all these days of practice is to put on upfront antibiotic. So one should understand it's a viral disease, and giving an effective antiviral which is available now serves the purpose than giving an antibiotic. So antibiotic should be given only when there is a strong suspicion of a community-acquired pneumonia and the presenting signs and symptoms are different, as we have discussed in the earlier presentation. So when it's a pandemic, when it's a peak of a pandemic, when we know the majority of 90 to 95% cases are COVID, so we must confidently upfront use antiviral and hit hard, hit fast. So coming to the theory part of favipiravir, also known as favipira, favilavir is an antiviral drug being developed by Toyoma Chemicals, Japan. Favipiravir is an antiviral agent that selectively and potently inhibits the RNA polymerase. Favipiravir has shown activity against influenza virus, West Nile virus, yellow fever virus, foot and mouth disease virus, as well as other flaviviruses, arenaviruses, bunya virus, and alpha virus. So in general, it's a broad spectrum antiviral. So we have got a very good broad spectrum antiviral to use upfront for majority of the viral illnesses. Favipiravir has been approved for experimental use against COVID-19 by regulatory agencies of Italy, China, and India. So the mechanism of action. So favipiravir is incorporated into the cells and converted to favipiravir ribofuranolase phosphates by host cell enzymes. The triphosphate form favipiravir RTP inhibits the viral RNA polymerase activity. So going by this mechanism, one can clearly understand it is going to stop the replication process by inhibiting the RNA polymerase activity. So that's where the use of it, early use comes into picture. So once we the viral loads start increasing from the day one. So as early as once we start the antiviral, the replication is stopped. So the viral load is being reduced to a great extent, and the viral clearance is achieved. So the maximum benefit is achieved for any antiviral once it started early into our body than being late. So to get the maximum benefit of any antiviral, it should be started as early as possible. So that's where the stress on history taking, the presentation, understanding the geographic settings around, and being a pragmatic approach comes into picture. So salient features of favipiravir: broad spectrum antiviral, as discussed. Early initiation within 72 hours helps to reduce the rapid viral progression, and early initiation helps to overcome the disease progression. Of course, once the viral load is reduced, the post-inflammatory phase is also reduced. So offers faster clearance within 4 days and symptomatic relief. So one should understand the symptomatic relief is very important. Majority of the patients end up for all those constitutional symptoms, dehydration, vomiting, or no fever. So all these symptoms, if it is come down, at a rapid progress rapidly, then the chances of admission is also less. So early initiation and avoiding hospitalization is the key, and reducing the hospitalization and overall treatment cost. So in a country like India, where there is a resource challenge, so we must be very pragmatic in approach. Our OPD should be strong, our primary health care centers, where such kind of antiviral use early will reduce the hospitalization burden, and it's saving a lot of resources, money to the government also, and to the patients also. So limit future complications of post-COVID-19 recovery. As I said, once the viral load is reduced, the post-inflammatory is also reduced. So the complications associated with the COVID also is reduced. So once the saturation goes, drops below 95, 94%, then of course we need to even add on a steroid with the antiviral. So one must be very judicious in using a steroid also at this setting, because one must not think that I've added an antiviral and the patient might not progress to a moderate setting. So one must monitor the pulse oximetry, track him regularly whether they're still in mild or they're moving into moderate category, and take the appropriate step of adding a steroid, so that to prevent the cytokine storm. So that's where we can limit the future complications of post-COVID-19 recovery. It's not just the antiviral. Right time of initiating steroid also is very important. And steroid should not be given in a mild or asymptomatic case, because you're going to increase the viral load by giving unwanted steroids in a mild or asymptomatic patients. So one must know when to initiate steroid, when to not initiate steroid also. So coming to the clinical trials of favipiravir, there are not much of studies, and this is a paper article suggesting of the favipiravir cutting the treatment time. So see, basically all those mild cases would have been better even after 7 days. But as I said, once the progression, once the symptoms are better, once they are free of symptoms, the chances of getting them admitted is also reduced. So that's where the picture of that's where the need of an antiviral comes into play. The patients clearing the virus 30% faster, so the symptoms are less. And COVID-19 task force recommend timely use of antiviral drug favipiravir to reduce the severity of infection. So it is all associated with how fast the viral load is getting cleared and how quickly we are giving. So both are interrelated. So one, to get the best benefit out of the antiviral, early initiation. That's what is the key of the talk. So there's one more study suggesting of 150 patients with mild to moderate symptoms were chosen to evaluate the efficacy and safety of favipiravir treatment versus standard supportive care alone. So within 48 hours of them testing positive for COVID-19. So there was all this study which indicated showed that the treatment time is cut down. So the patients who were requiring more number of days to get cleared from infection or symptoms took lesser time once early antiviral favipiravir is initiated with them. And patients receiving dose of 3,600 mg favipiravir on day 1, that's usually we divided 1,800 BD, followed by 800 mg twice daily to a maximum of 14 days, but we usually limit to 5 to 7 days itself, along with standard supportive care. So randomization was stratified based on disease severity into mild and moderate cases. The slide is not moving. Yeah. So favipiravir seemed to have a faster and clinical cure, and more importantly, faster viral clearance than those randomized to the routine care group. In the study, it has been found that 69.8% of patients in the favipiravir treatment achieved clinical cure by day 4. Means all their symptoms, shortness of breath, cough, fatigue, all reduced by day 4. So that means it is clear to show the viral clearance is achieved faster by initiating early within 48 to 72 hours. So the gist of this talk is hit hard, early. It's not just hitting hard; it should be hitting early also. That's where antiviral is acting, and how better the results are achieved. So dosage of favipiravir, as discussed, 1,800 BD on day 1 and 800 BD for other 7 days. So favipiravir side effects or special use in such special population, coming to that, it should be avoided in pregnant women, lactating mother, patients with gout who have a high uric acid levels. Children, of course, we are not using it all because majority of the children are mildly symptomatic. And geriatric patients, appropriate caution should be exercised. As far as my experience is considered, my better results are, what I've seen is more used in 30 years to 60, 65 years. Not I've avoided using in too old individuals like above 65 to 75 years. I've not found much of benefit, and invariably they'll end up getting into moderate sickness and taking a remedies. Of course, renal impairment and hepatic impairment. So getting a serum creatine, SGOT, SGPT marker at least once is a must in those suspected individuals who have a renal and hepatic impairment. And of course, drug interactions we are not encountered much, but it should be noticed that pyrazinamide, theophylline, which if any TB patient is coming with COVID infection, or any other asthma COPD patient who is of theophylline also. So as I discussed, benefits of starting antiviral early within 72 hours, faster clearance within 4 days, and symptomatic relief within 7 days, reduces the chances of hospitalization and reduces the overall treatment cost, and limits the future complications post-19 recovery. So currently, treatment to family members, we are doing, we do add azithromycin or doxycycline, zinc and vitamin C therapy. There have been studies suggesting alpha lipoic acid, vitamin D also, and NAC, N-acetylcysteine therapy, also as a chelating therapy for moderate to severe cases. Of course, for mild cases, we are limiting with vitamin C and zinc only. Post COVID-19 complications are observed in home quarantined asymptomatic patients. I have not encountered any case as such with complication in asymptomatic patient. Definitely, they'll have some symptoms. We need to take a detailed history, check their pulse oximetry. So, majority of the patients are the ones who had moderate to severe symptoms only, ending up with post-COVID complications. Thus, there is a need of antiviral therapy even in asymptomatic patients also. For this comment, I will be a little precise to tell, because those individuals who are having comorbidities and in the age of 35 to 60 years, having diabetes, pre-diabetic, hypertension, thyroid. So in those patients asymptomatic, definitely I will add a favipiravir, because most of them start getting symptoms from the second or third day. So it's better to add an antiviral and prevent the post symptoms also, and avoid them hospitalization also. In a healthy individual who is young, healthy, who's not having any comorbidity, I'll just observe and see for 1 or 2 days, and then act appropriately. So post-COVID-19 complications, discuss pulmonary fibrosis, cardiovascular complications, because we all know it's a prothrombotic state in a COVID-19 infection. So the role of adding an effective anticoagulant also comes into picture. We do give for 1 to 2 months of anticoagulant, dabigatran, rivaroxaban. So that must be continued at least for 2 months, especially for patients with comorbidities and age above 40, 45 years patients. Of course, diabetes, blood pressure, deep vein thrombosis. Many patients, you might have noticed, patients have been diagnosed diabetes once they get COVID-19 infection. They give a history that they never had a raised blood sugars, and post-COVID only they have started developing diabetes, which is yet to studies need to come on that aspect also. Because I am seeing a lot of new patients presenting to us on newly onset diabetes. Either they must not have recognized diabetes, or is it that something related to a COVID-19 complication? It's yet to studies need to come in detail about that. Blood pressure and deep vein thrombosis. Of course, deep vein, I said, if anticoagulant is not prescribed, many do end up in deep vein thrombosis. And of course, cardiovascular complications like myocarditis also. So diagnostic test post-COVID-19 recovery, we do keep a close follow-up on all the patients. Of course, we are not doing a PFT now. Definitely, we can do a single breath count, peak flow meter, and D-dimer. That's what as I said, it's having a high negative predictive value, so you can virtually rule out pulmonary embolism. So that can be done if there is an 2D echo suggesting of a RARV dilatation, or the patient's presents with an acute shortness of breath post discharge. So we appropriate tests can be done, and sugar test. Of course, there are raised sugars. We need to take a dietitian opinion also on that.
Hello.
Yes.
Yeah, when it comes to D-dimer, see, just D-dimer being high does not say whether it is pulmonary embolism. As Chetan said, it is the clinical context which is very, very important. If the patient has got an acute onset of breathlessness or something like that, and at that juncture, if your D-dimer turns out to be positive, then it will be.
It has to be confirmed with the CTPA.
Yeah. Any questions? Mona?
Is not online, I think. Yeah.
Sir, we have a number of questions here.
Hmm.
So I would just read them out so for further discussions. So there's a query from Dr. Shrikant. He says that, of course, in this era where vaccine is in vogue, will vaccine play an important role in COVID-19?
I mean, see, it is very too early to comment about the what to say, the outcomes of vaccine. See, vaccines have got their own advantages and disadvantages. See, although Edward Jenner was what to say was identified as a smallpox vaccine, smallpox did not go away completely soon after start getting the vaccine. See, it will also phase out over a period of time. Yeah, so once the vaccine is in the market, once we start using it regularly, then only we will be able to say or comment upon the quality of vaccine. And if you ask me, I think let us keep it aside because it is yet to come. Okay, so how it is, when it is going to come to India, we don't know. Just ifs and buts. It is all media hype which is going on. Let us wait and watch. For the time being, let us focus on identifying the cases and treating them.
Yeah.
Okay, that is most important. And no vaccine will provide you 100% what to say protection. So for somebody who has taken a vaccine, it is either a all or none phenomena. He is completely protected or he might get an infection. Although if you take the percentage 80% effective, 70% effective, for that particular individual, it is a all or none phenomena. So it is either protected completely or not protected completely. That is what is important. So let us keep vaccines as a, just like let us see this vaccine also as a any other vaccine. How much importance are we giving for vaccination of pneumonia? How much infection what to say importance we are giving for vaccination against H1N1? I think the same thing is going to apply here also, but it is very early to comment upon the efficacy and the outcomes of vaccination.
Yeah, and they must understand that strains keep changing. It's not that they're immune throughout their life.
Right. Perfectly said, sir. Okay. There's another question come in about favipiravir. Now, should favipiravir be taken as prophylaxis by other family members if just in case one family member is detected with COVID-19?
Yeah. See, I'll answer, sir.
Yeah, please.
Yeah. See, one must understand if there are 10 members in a family or in an office, if one becomes positive, not 10 will get equally exposed to a virus or any infection for that matter. So that was the initial fear and stigma in the initial phase 1, phase 2 of the pandemic. So to prevent the spread of COVID, that was logical. Testing, giving prophylaxis, quarantining, everything. So one must understand not those all exposed 12 will catch an infection. It depends on their immunity, ACE2 receptors, how is the viral load, for which viral load they are exposed, everything matters.
Okay.
So, but definitely, yes, those risky patients, those comorbidities, those obese patients, or those aged above 45, 50 years above patients need to be very, pragmatic approach. Means they should check their pulse oximetry. They should, not undermine their symptoms, thinking it as a seasonal allergy or cough. So for those patients, of course, we can't give not a prophylaxis. Definitely, if they get even a small bout of cough, fever, at least chills, immediately on that day we must start favipiravir and complete the dose.
Dr. Sandeep, any views from your side?
See, prophylaxis again, see what to say, post-exposure prophylaxis and all those things are there. But let us keep it simple. If any of the family member is asymptomatic, because what we have observed is people who get, for example, if a single family member develops a COVID-19, in that fear, everybody takes these medicines. And later, after 15 days, 20 days, after 1 month, somebody else also develops that COVID-19. So, see, there is no point in taking the medicines unnecessarily. So,
Yes.
if they develop any kind of symptom, okay,
Yes.
whether it is a minutest of the symptom, whether it is a simple headache, fever, cough, chills,
Then we need to start, yeah.
or something like that, diarrhea, abdominal pain, nausea, dyspepsia, and anosmia. If any of such symptoms develop, the first sign of a symptom, they should be started on treatment because they are already exposed to COVID-19 in a person or COVID-19 patient. If they are not symptomatic, if they are, they are reasonably all right, I don't think there is any need for any kind of prophylaxis in them, because the chances of them developing the infection later will definitely be there. Okay, prophylaxis does not ensure that the patient will never develop infection.
Yeah.
Okay, so that thing we have to keep in mind. So rather than doing that, I think we can wait for them. We can keep them under constant observation, or serious observation. And once we feel that the patient is having a symptom because of COVID-19, then we can start them on proper treatment only, rather than prophylaxis.
Because we have seen so many patients taking 3-4 times all in this pandemic.
That is what. See, whatever we have understood is only partial about COVID-19. What is the real mode of spread, how it spreads, when it spreads, how, all those things are still a mystery only. If you ask me as an expert, there are so many individuals who are living together. One person is having infection, the other person is not at all infected. A person who is a neighbor of that particular house, he develops infection. All those sorts of things are there. Okay, for the time being, let us be vigilant in identifying the cases. That is very, very important. So any case of fever, any case of chills, any case of upper respiratory tract infection, any case of cough, think of COVID. Once you think of COVID, start them on treatment. That's it. That is all is required.
We should identify the symptoms early. That's it.
See, basically, as a medical fraternity, we should accept that it is a viral infection, and we all know how. See, these TV media people, they say no, video has gone viral. That means it is spreading unstoppable. So that is how it is. So you cannot prevent a viral disease. Let us be practical. That too, when the mode of spread is through droplet infections or droplet infestations or something like that. So let us identify the cases earlier. Let us treat them empirically. There is no problem in starting a patient on antivirals or favipiravir empirically. Don't hesitate, because you will be saving 8 out of 10 people by starting them on antivirals at the right time. So aptly, the title, hit hard, hit early. That is very, very important.
Right. Thank you, Dr. Sandeep.
What is the role of vitamin C and zinc in asymptomatic COVID-19 patients? Would vitamin C and zinc play a role in building immunity? How many days should patients take to ensure the immunity? Chetan, you want to add, or should I take this up?
Take it up. It's antioxidant. It can be used up to 1 to 2 months.
That is what. See, vitamin C, zinc have been, I think, those pharma companies or whoever have manufactured this vitamin C and zinc, they would have had their sales of their lifetime, I think. They have been used like anything. See, vitamin C is a very well known antioxidant. Zinc is also, every micro element is very, very important for immunity or overall homeostasis of our body. Okay, how much they are going to be beneficial, how long they are going to be used, how long they should be used, there is no answer for it, because there is still a question mark. Who told vitamin C? Where is the trial? Vitamin C, zinc are protective, or they are not immune, are shown to be protective in COVID-19. There is no trial which has happened on vitamin C or zinc supplements. For the time being,
but there have been some expert telling about high dose vitamin C helpful in moderate cases also. High dose of vitamin C. As a chelation therapy with.
Because they are not harmful. See, vitamin C is not harmful. Zinc is not harmful. In medicine, what we have is something called as a risk-benefit analysis. So if the risk is minimal, whatever benefit it gives, let it give. There is no harm in giving it. Okay, what we generally do is we generally give it for 1 month in every patient. Vitamin C also, vitamin zinc also. This is what we are practicing.
The newer picture of,
I don't have any evidence.
So there is a newer studies also, some expert opinions also telling of NAC, N-acetylcysteine, glutathione, alpha lipoic acid, along with vitamin D3, zinc, and vitamin C. So all this as a chelation. So to reduce the inflammation, a lot of neurosurgeons have used in the post-neurosurgery cases. So that's the concept, to reduce the inflammation, especially in those moderate severe cases, to reduce the inflammation. There have been some experts advocating strongly in Mumbai and Delhi doctors also from that.
Should favipiravir be taken as prophylaxis by other one person? We have taken it already. Which test would be preferred to understand post-COVID-19 complications? And what is the suggested frequency to undergo the same?
CRP is the one marker I'm doing regularly. Means when the post follow-up, that's it. And we keep a watch on the symptoms, pulse oximetry to see. And of course, if the fibrosis is very extent, we do get a HRCT done to know the extent of fibrosis, to see whether they're going into a really ILD kind of picture or whether they're reversing. So for that purpose, we are doing only HRCT in those selective cases only. And of course, CRP to see as a marker, as an inflammation marker. Nothing as specific, so and so marker is there. It's basically clinical judgment. If we find any sudden shortness of breath, acute lower limb pain, of course we do get a Doppler scan done, D-dimer done, 2D echo done. So based on how they present, we do the test. That's it. There's no anything definitive marker to say I'll do this and I will find out some other complication in that patient.
Right, sir. Dr. Sandeep?
Yeah, I totally agree. See, basically, simple majority of the time, as you all know, 80% of them will be asymptomatic or will be mildly symptomatic. In moderate cases, they will be discharged somewhere by the end of 2 to 3 weeks in the hospital. Severe cases, they take slightly longer duration. See, what are the possible complications? The possible complications are a thrombotic event like a DVT or a pulmonary embolism or a stroke or an MI kind of a thing. The second possibility is post-COVID fibrosis leading to hypoxia and all those things. Other than that, there are no, this diabetes, this hypertension and all those things. It is yet to be very, very clear. As it is the first round of pandemic, I think we are not very clear on what is exactly what. For example, maybe in tuberculosis or something like that, we follow up with the sputum examination whether the patient is having active tuberculosis or not having active tuberculosis. So there is nothing which is clearly shown to be a marker of the complication or maybe a progression of the COVID-19 disease. For me, if you ask me, as long as the oxygenation is normal, as long as the patient is feeling comfortable,
Yes.
The investigation. Investigations carry importance only in the clinical context. If the patient is asymptomatic as compared to last week, he is feeling much more better.
Nothing to do.
Unfortunately, CRP is the same or is showing a slightly increasing trend. I think that should not make us worry. Okay, we can plainly let it go and wait for the patient to return to us with some or the other symptom, because we don't have anything much to offer other than steroids and these antivirals. What do we have to offer? Okay, that is most important. So I think it is a more of a clinical thing which I follow. I believe. I think Chetan would also will agree. And as
yes, definitely. The clinical approach should become strong and stronger. After this COVID, the clinical approach should be the strongest.
Yes,
and it should become less dependent on the reports and investigation. Somewhere that it has taken the other route after the pandemic. We are more dependent on investigation, more on swab reports, but forgetting the clinical scenario totally. Yes, Mona, next question.
Sir, I think we have these many questions. There are no more questions coming up
Anything
now.
from your side? Yeah.
No, sir. I think majority of the questions, doubts, whatever the audience had has been answered. So any views, any concluding remarks from Dr. Sandeep and Dr. Chetan?
So concluding remarks, most important thing is we are still in the midst of a pandemic. Any patient presenting to us with a fever, myalgia and upper respiratory tract infection is a COVID. There should not be any hesitation in starting somebody on antivirals, empirical antiviral, because don't bother much about H1N1, don't bother much about rhinovirus or adenovirus, because they are not very, very as harmful as this particular COVID-19. So instead of starting them on empirical antibiotics, you are very much justified. You are very much helping them by starting them on empirical antivirals. So hit hard, hit early. Don't wait for the reports. Don't wait for the investigations. I mean, just have a look at the pulse oximeter. If they are in mild to moderate category, start them on oral antivirals. There should not be any hesitation or any delay in starting them on antivirals. This is the take home message. All cases coming to you with fever, myalgia and upper respiratory tract are COVID-19 unless otherwise proved.
Yes.
So there should not be any hesitation in starting them on empirical antiviral favipiravir. Without any hesitation, you can start them instead of antibiotic. Okay, these are the two important things. And third important thing is monitor them for at least 2 weeks. Okay, they can progress from mild to moderate to severe anytime during these 2 weeks. Have a sharp eye on them, ask them to monitor the oxygen saturation, and anytime if the saturation falls below 90, ask them to get admitted and switch over to the other antiviral, that is remdesivir. So this is about in a nutshell about the take home message. I think Chetan, you want to add anything?
Yes, I think you have covered everything. One, what I have observed is still the over dependence on swab reports. That has to come down. We know that it's only 60% sensitive. Still, many people are relying on it, wasting their time. That should not happen. It should be more of a syndromic approach, and let us rely more on the symptoms. Diagnose early, treat early, hit hard, hit fast, treat early to bring the better outcome. So the outcome is better once you diagnose, once you take a detailed history, proper history, act early and not wasting time, not giving reasons, not denying them the early treatment. So that has to be done importantly. So to avoid, already we have seen the number of deaths, mortality, morbidity. If we want to seriously bring it down, we need to understand this concept in our mind, in our heart. That's it, I can tell. Yeah.
Thank you so much, Dr. Sandeep and Dr. Chetan, for giving your valuable thoughts on the antivirals in COVID-19. We also thank the audience. We had a fabulous number, 200 plus, coming up as part of the audience. They were, very grateful to you, to both of you, to share your thoughts. And we thank the audience. We thank the panel. Thank you so much from Hetero Healthcare.
Thank you.
Thank you.
Thank you.